My name is David Sears. I am the Director of Healthcare Quality for AMIND. I'm also an Assistant Clinical Professor of Medicine at the University of California, San Francisco. I have a specialty in internal medicine and a subspecialty in infectious diseases. Next, we will talk about the risk factors for COVID-19 acquisition and severe disease. Following are people who are considered to be at higher risk for acquiring COVID-19. Again, all correctional residents should be considered at risk for acquiring COVID-19, even if there have been no cases identified within a facility. Certain individuals will be at higher risk for acquisition related to the proximity, duration, and nature of exposure to an infected individual or individuals. And again, those infected individuals could be corrections officers, or they could be staff, or they could be fellow residents. It's worth noting the CDC definition of a close contact. You are considered a close contact if you are in contact with somebody who has confirmed COVID-19, you are not wearing PPE, and you are within 6 feet for a prolonged period. The CDC does not exactly define a prolonged period, and it's not a black and white decision, but many in the community will define that as prolonged being 10 minutes or greater. Additionally, you're considered a close contact if you come into direct contact with infectious secretions of a known COVID-19 patient. So, in corrections, the following are scenarios where we would consider somebody to be high risk. Probably the highest risk for acquiring COVID-19 in corrections is being a cellmate of a patient with COVID-19. Following that, being a resident worker or volunteer caring for a patient with COVID-19 without the use of PPE would put you at substantial risk. Next on the list would be another close contact of a patient with COVID-19. So maybe you weren't the cellmate or the resident worker or volunteer, but you were within 6 feet for a prolonged period with somebody who is known to be infected. Finally, we should also consider residents transferring from a facility with sustained COVID-19 transmission in the last 14 days, as well as residents who are sharing common spaces like yard, shower, dining area with a patient or employee with COVID-19. Then, in addition to being high risk for acquiring COVID-19, there are also a number of patients who are higher risk for developing severe disease once infected. The CDC defines the following adults as high risk for severe COVID-19. Older adults, and this risk increases exponentially with age, but really starts to take off around the age of 60 or 65. Additionally, residents of nursing homes or other long-term care facilities are considered to be higher risk for severe disease, as well as individuals with high-risk medical conditions. The high-risk medical conditions, particularly if they're not well controlled, include those with chronic lung disease, serious heart conditions, diabetes, renal failure, cirrhosis, morbid obesity, and then a number of immunocompromising conditions, including cancer patients undergoing treatment, HIV infection, organ transplantation, as well as others such as the chronic use of prednisone or other immunosuppressive agents. Next, let's talk about COVID-19 clinical manifestations. Once an individual is exposed to COVID-19, the usual incubation period is about 5 days between exposure and the development of symptoms, if that individual is going to develop symptoms. 99% of patients who will develop symptoms do so by 14 days. And that's the reason for the 14-day quarantine following exposure. Most of what we know about the symptoms of COVID-19 come from case series of hospitalized patients in China, and now we have some increasing data from the United States. These case series show us that fever, cough, particularly dry cough, fatigue, shortness of breath, muscle pain, sore throat, headache, chills, nausea and vomiting, nasal congestion, and diarrhea can be the most common symptoms of COVID-19 in hospitalized patients. Fever, cough, and fatigue are hands down the most prominent symptoms. In the United States, our initial case series have shown slightly higher rates of GI symptoms, nausea, vomiting, and diarrhea, and that occurs in approximately 20 to 25% of patients. The challenge with symptoms in outpatients is that the presentation can be much more subtle. As previously discussed, many patients with COVID-19 may be entirely asymptomatic and may remain so. There also is a broad range of respiratory symptoms, particularly in outpatients, many of whom may have symptoms that look like routine viral URIs that are not severe in nature. So sore throat, nasal congestion, plus minus mild cough may be a presentation of COVID-19 in somebody who is not sick enough to be admitted to the hospital. In addition, a number of cases without cough or dyspnea have been described, including presentations where GI symptoms were the presenting complaint, fever was the only complaint, conjunctivitis was the presenting complaint, or a loss of the sense of smell or taste abnormalities were the presenting features. Severe disease appears to occur in fewer than 10% of patients with COVID-19, and for many patients, just like the patient we discussed in the case intro, the decompensation occurred late in the course of illness. In this case series from China, which mirrors much of the presentation that we have seen in the United States, sepsis occurred about 9 days after the onset of symptoms, ARDS at 12 days, ICU admission at 12 days, mechanical ventilation about 15 days after the onset of symptoms. So now let's review the takeaway points for the sections describing risk factors for COVID-19 acquisition and severe disease, as well as the section on COVID-19 clinical manifestations. First, increased age, particularly those 65 or older, and poorly controlled comorbid illnesses are important risk factors for severe disease. Additionally, the incubation period is an average of 5 days, but can be up to 14 days. Cough, fever, and dyspnea are the most common symptoms, and really the more we look, the more we find atypical presentations. Clinical deterioration often happens late in the course of illness, which certainly has implications for monitoring our patients and figuring out an appropriate disposition. Finally, I'd like to remind you that AMIND at UCSF, that's our organization, is a health-focused correctional culture change program led by experts in medicine, public health, and correctional health and policy. We work with U.S. corrections departments to promote the health and well-being of people who live and work in U.S. jails and prisons. I'd like to thank you so much for your interest in this presentation, and really thank you for your service, and hope that you stay safe in caring for these patients. We understand there's a lot of information. If you have additional questions, or if there's a topic or question you'd like us to address in the future video, please email our program manager, Kevin Reeder. And you can visit us at amind.us. Thank you.